My name is Mary. I'm a third-year medical student at the Baylor College of Medicine, and I'll be presenting the association between complete blood count ratios and intraamniotic infection in women with sexually transmitted infection during pregnancy. The overarching goal of this project was multifold. We were interested in assessing the utility of the complete blood count in predicting adverse neonatal and maternal outcomes in women with STI versus those without STI during pregnancy. Background. Adverse birth outcomes can impact neonatal health during the immediate perinatal period and beyond. It is a public health priority to identify an affordable and accessible, time-sensitive method to prevent or attenuate adverse birth outcomes. Intrauterine inflammation, importantly sexually transmitted infection, plays an important causal role and contributes to the pathology of many adverse birth outcomes and other pregnancy-related complications. A multitude of conditions with inflammation have been associated with inflammation markers from the complete blood count with differentials, especially ratios of different blood cell types. This association has been studied and has held across different times throughout pregnancy. To date, there are no studies that investigate the association between CBC ratios and adverse birth outcomes in pregnant patients with STI. Generally, there is a paucity of data over the association between STI and CBC indices, which includes CBC values and ratios. We postulate CBC analysis presents a practical and affordable opportunity to elucidate the mechanism of STI-induced inflammation and, importantly, apply that knowledge to predict and prevent STI-mediated adverse birth outcomes. We investigated the association between CBC indices and adverse maternal and neonatal outcomes in pregnant women with antenatal STI compared to pregnant women without STI at OB intake to care and third trimester. We performed a prospective cohort study of women who delivered between September 2019 and September 2020 at several hospitals in the Texas Medical Center. Demographic, obstetric, and neonatal variables are abstracted, including STI status, preterm birth, low birth weight, neonatal sepsis, intraamniotic infection, and endometritis. We recorded CBC values at OB intake to care and third trimester and calculated ratios of neutrophil to lymphocyte, lymphocyte to monocyte, and platelet to lymphocyte. Of the 931 women with CBC indices recorded, 194 were STI positive. There were no significant differences in CBC indices based on infection type. We also assessed associations between each CBC index and each perinatal outcome in the STI positive and STI negative group. When adjusted for STI, significant odds ratios were found with intraamniotic infection and decreased lymphocyte to monocyte ratio at intake for the STI negative group, and increased platelet to lymphocyte ratio and neutrophil to lymphocyte ratio in the STI group. Intrauterine inflammation is a well-established cause of adverse birth outcomes and results in an inflammatory milieu that promotes labor. Intraamniotic infection is a major risk factor for preterm birth due to activation of the pro-inflammatory cascade. Inflammatory milieu can be characterized by lab tests, including cytokine assays and CBC with differentials. The latter is a routine, inexpensive, and minimally invasive test, ideally done multiple times throughout prenatal care. Recent studies have suggested the utility of the neutrophil to lymphocyte ratio in patients at risk for preterm birth and eventual preterm birth. In addition, increased platelet activation, represented by the platelet to lymphocyte ratio, has been associated with adverse birth outcomes, including low birth weight and preterm pre-labor rupture of membranes. To knowledge, our study is the first to investigate and find an association between CBC indices at OB intake to care and the third trimester in women with adverse birth outcomes according to STI status. In our study, the lymphocyte to monocyte ratio at OB intake to care was negatively correlated with intraamniotic infection in the STI negative group, and platelet to lymphocyte and neutrophil to lymphocyte ratios in the third trimester were positively correlated with intraamniotic infection in the STI group. Limitations of our study include different number of patients with CBC at OB intake and third trimester, and variability in CBC collection among different patients, and size sample and likely underestimate of true cases with intraamniotic infection. CBC with differential is not a sensitive or specific standalone measure for prediction of adverse birth outcomes. Rather, it is more useful in combination with other predictive tools for adverse birth outcomes. Future analysis includes a more detailed investigation over the association between CBC indices and intraamniotic infection, which can further subtype intraamniotic infection into subclinical/histologic and clinical, and may be useful especially in identifying cases of at-risk or of eventual subclinical intraamniotic infection outside of the postpartum placental histologic analysis. Furthermore, investigation of adverse birth outcomes and CBC values in the same patient may provide information about changes in the inflammatory profile throughout pregnancy.